could be good for me. Lately I was feeling like I need a purpose. But when you talk to me, give me the impression that I won't scratch your surface.
So today we are going to read brachial plexus. So let's first visualize the whole diagram, and we have to memorize this diagram very sincerely and very carefully. And in every prof, this is the main topic of interest of all the examiners. So let's start. First of all, we will start with the roots of the brachial plexus. Now, every root has an anterior rami as well as posterior rami. Now, we've seen that here there is C5 there, C6, C7, C8 and T1. All these, the 5 root values forms the root of the whole brachial plexus. Now, the roots of the C5 and C6 come to join and forms the superior trunk. Root C7 alone forms the middle trunk, and root C8 and T1 forms the inferior trunk. Now let's study the gross brachial plexus part first, then we will go deeper. So the root, first of all, it comes the roots, then trunks, then divisions, then cords, then terminal nerves. Now first, as we started, C5, C6 forms the superior trunk, and its anterior division along with the posterior division of the middle trunk, its anterior division along with the posterior division of the middle trunk comes and forms the lateral cord. Similarly, the posterior division of the middle one comes and forms the posterior cord. Now, this cord along with the anterior division forms the middle cord. So, the anterior division along with this division of the middle cord forms the lateral, the posterior division of the superior trunk, the posterior division of the middle trunk, and the posterior division of the inferior trunk. These three posterior divisions forms the posterior cord of the brachial plexus. Now, here from the lateral cord, it divides into the musculocutaneous. One branch comes and forms the median nerve along with a branch of the medial cord. Here you see. Now, the posterior cord gets divided into the radial nerve and the axillary nerve, and the medial cord gets divided, one forming the median nerve along with the branch of the lateral cord, and another forming the ulnar nerve. Yes. Now let's see the further subdivisions and the further sub-branches that has arisen from different trunks, divisions, cords, or the roots, etc. Now, here we can see that dorsal scapular nerve has arisen from the C5 root. Also, a nerve is there to the nerve to phrenic. Now, a division from branch from the C5, from C6, from C7 has directly came and downward, which is the long thoracic nerve. Now in the trunk region, here from the superior trunk, suprascapular nerve arises, and the nerve to subclavius also arises from the superior trunk. Now this is the gross diagram of the brachial plexus. Now let's see an important topic, that is the Erb's point. Now, what is Erb's point? Erb's point. So it is the meeting point of the 6 nerves in the territory of upper trunk. Meeting point of 6 nerves in the territory of upper trunk. Now, what are the 6 nerves? Let's mention. Root of C5, root of C6, supraclavicular nerve, nerve to subclavius. 5. Anterior division of upper trunk, anterior division of upper trunk. 6. Posterior division of upper trunk. So these are the 6 nerves in the territory of that upper trunk forming the Ubbs point. Now we can appreciate here that here is, look at the diagram right side, this is the Ubbs point. Just we have mentioned the supraclavicular nerve, here is the supraclavicular nerve, here is the nerve to subclavius, C5, C6 roots, anterior division, posterior division, right? Now, what are the injuries leading to Ubbs palsy? So the injury to Ubbs point leading to the Ubbs palsy. Now, number 1, C5, C6 injury. Number 2. So now the muscles supplied by C5 and C6 are compromised. So the muscles supplied by the roots, that is C5 and C6, are compromised. That is the shoulder and scapular muscles. Shoulder and scapular muscles. Now, nerves involved are, that means what are the nerves leading to the injury? Now, nerves involved. Nerves involved. Number 1 is supraclavicular nerve. Sorry, suprascapular nerve. Suprascapular. Number 2, nerve to subclavius. Number 3, musculocutaneous. Number 4, axillary nerve. Number 5, radial nerve. And number 6, median nerve. Okay. Now the distal area to the nerve is always involved. Now the thing we have to remember here is that, so the distal area is involved, not the proximal. Always remember that injury, suppose here injury has occurred, injury, and nerve, suppose this is the nerve. So if injury has occurred in this position of the nerve, so nerve conduction occurs in this process, upper to lower. Now the nerve conduction from upper to lower, in this way the nerve conduction occurs. So if injury is at this level, here distal to the injury is involved and proximal to injury is not involved. So this is the proximal part, this is the distal part. All these are involved in the injury and above the part are spared. So what are the clinical features of Ubbs palsy? So Ubbs palsy clinical features. Number 1. Policeman tip hand deformity. Policeman tip hand deformity. Number 2. Sensory loss in the lateral aspect of upper limb. Sensory loss in the lateral aspect of upper limb. Now, some part get anesthetized, and which part? Let's see. Regimental patch anesthesia. Here, root value of C5, axillary nerve and skin on upper part of deltoid has sensory loss. So all these things are having anesthetic effect due to, so they are not working. Regimental anesthesia. Okay. Now, nerves involved in the C5-6 injury. So, nerves involving C5-6 injury. Number 1, axillary nerve. Total injury. Axillary nerve total injury. C5, C6. Number 2, musculocutaneous partial injury. C5, 6, 7. It is C5, C6 and C7. Number 3, radial nerve and partial injury. C5, 6, 7, 8. So one thing is common in everything, all the three, that is C5, C6, C5, C6, C5, C6. Yes. Now coming to the clinical features. So it's the policeman tip hand deformity. Now, the Erb's palsy clinical features. Now we can see that first here the box. Here the nerves involved, the causes of injury and the clinical features are clearly mentioned. So the clinical feature is policeman tip hand deformity. Like the policeman takes the tip in the hand and the palsy mimics that posture. So let's see what's seen in the image. Adduction and medial rotation of the shoulder joint. Number 1, extension of the elbow and pronation at the radial ulnar joint. Okay, so the clinical features: policeman tip hand deformity, sensory loss of in lateral aspect of upper limb. So the sensory loss in lateral aspect of upper limb. Now, the regimental batch anesthesia. Root value C5, axillary nerve involved, and the skin on upper part of the deltoid muscle has sensory loss. Now, what is the nerves involved? So the nerves involved in C5-6 injury are axillary nerve, there is total injury with the root value of C5-C6, musculocutaneous nerve, partial injury with the root value of C5, 6 and 7, and radial nerve partial injury with the root value of C5, 6, 7, 8. Now, what the thing is common is all have a root value of C5 and 6 common. Now, what is policeman tip hand deformity? So the toe shoulder, coming to the shoulder joint, the difficulty in abduction and lateral rotation. The elbow joint, difficulty in flexion. The radial ulnar joint, difficulty in supination. Now, so the shoulder having adduction and medial rotation, elbow is in flexion position and radial joint in pronation. So the overall position, okay, of all these three giving rise to policeman tip hand deformity. Yes. Now coming to the Klumpke's palsy after the Ab's palsy. No, Klumpke's palsy. So it's in the C8T1 injury, giving rise to clawhand deformity and special injury to the T1. Now the muscles involved, hand muscles involved, lumbricals and intrasi, all these are compromised. Now the Horner syndrome. What is Horner syndrome? Ptosis due to paralysis. Ptosis due to paralysis of superior tarsal muscle, that is the molar muscle, and meiosis due to paralysis of dilator pupillae. Now coming to the clawhand deformity, the lumbricals and the intrasi actions, the metacarpophalangeal joint flexion and interphalangeal joint extension. So the MCP extension and the IP flexion in injury. So it's lead to claw hand. Now, so we can appreciate that in claw hand deformity, normally that is this thing, but in claw hand, interphalangeal joint flexion, but metacarpophalangeal joint extension. Okay, and affected eyelid droops, there is ptosis, drooping of the eyelid, and meiosis, it's due to the Horner syndrome. Now the cords, they're present in the axilla. How it's formed? Formed with lateral, the anterior division of upper and middle trunk. Upper and middle trunk joins to form the lateral cord. The posterior division of upper, middle and lower trunk joins to form the posterior cord. Anterior division of the lower trunk continues as the middle cord. This is the ulnar nerve. So the nerves basically arises from the lateral cord, musculocutaneous nerves. From posterior there is the radial nerve and medial there is the ulnar nerve. Okay, and median nerve that is formed by the contribution by the lateral and the middle cord. So here the diagram it is, which all can appreciate that. Yes, this is the radial nerve, this is the median nerve. Now we can trace. So it's said that the median nerve is contributed by the lateral and the medial cord. So let's trace back. Median nerve, this is the median nerve. Going back. Yes, this is the medial cord. See, this is the medial cord. Again, this branch going back, and this is the lateral cord. So there is the lateral and medial cord. Okay. Now we can appreciate the posterior cords of the brachial plexus having, see, it's the radial nerve. This is the posterior cord of the brachial plexus. Other nerves are the lower subscapular, thoracodorsal, upper subscapular nerve, long thoracic, latissimus dorsi muscle. This is the anterior view. So thank you. If you are new to this channel, please consider subscribing and hit the bell icon for more notifications. Stay tuned. All have a good day.